sorry.
You can be seated. Mrs. Zion, you ready to proceed? You're still under oath. Okay, yeah, have a seat and relax.
Showing you again the same exhibit from before for purposes of refreshing memory and also the order that we showed you here. I think I had a question about where this note came from. This is actually sort of that sheet.
Oh, thank you. This would help me, yes. Okay.
And then also looking at an order form from the same exhibit that has your name on it.
Okay.
Does that help you recall what his status was when you saw him that night?
Okay. Yes.
Is your memory refreshed now as to his status regarding his the level of care he and or his family wanted him to receive when you came on shift that night?
Full resuscitation.
Okay. Now you've gone through some of the issues that he's having. At some point, is there a discussion with the family about changing that full resuscitation status?
There is.
Tell us about, in your mind's eye, looking back on this, how that occurred. Who came to who? What was discussed?
So I was sitting at the nurse's station in the CVICU. It's more of an open nurse's station in comparison to the other side. I was approached by a family member who called me and approached me and voiced their desire to withdraw care.
What happened next?
I told them, I said, I understand. Well, this was also after we presented those things that I discussed earlier about his change with the leg and everything as well. They approached me. I said, okay, I'm understanding what you're saying, but I can't do anything. The doctor has to be at the bedside to hear this. So I called Dr. Husel. Dr. Husel came to the bedside, and then they basically voiced the same desire to stop all treatment.
All right. At this point, is your patient stable?
To me, no.
Is there anything rapidly declining about his condition at this point besides what you've described?
I've described everything that I can think of.
Okay. Do you recall what time of the evening this would have been?
9, maybe, approximately 9 o'clock, a couple hours into the shift.
If the note says this conversation occurred at 11 p.m. In the medical records, would that fit with your memory?
Yeah, that would be more accurate, yeah.
Okay. So once the decision is made by the family to withdraw all care, well, that's
DNRCC.
DNRCC, to withdraw life support care. Let's phrase it that way.
Yes.
What, if anything, is given to you as orders regarding this procedure?
Verbal orders for medications.
Okay. By whom?
Dr. Husel.
And what were the verbal orders for the medications that were given to you?
The numbers are, once again, like the first, they're blurring together, but I know it was 1,000 micrograms of fentanyl was one of them, and there was some dosage of Midazolam or Versed.
Is there anything I could show you which would help refresh your recollection as to the amount of medication that was ordered?
Yes.
Before we get into that, so it's 1,000 micrograms of fentanyl. Were you aware at this point of any pain medication that he had received previous to this order of 1,000 micrograms of fentanyl?
Not that I don't remember.
Okay. Had you been actively treating your patient for pain throughout the evening?
I don't believe that I actually dosed him with any pain medication that evening until the withdrawal of care.
If the records were to reflect that he had been receiving a drip of 25 micrograms of fentanyl infusion throughout his stay, would that help refresh your memory?
Yeah, it would.
And what's the difference, based on your training and experience back then, between a drip and an IV?
For the reasons we've already discussed, overruled.
No, I'm talking about counsel.
Okay. Stay back on over. Go ahead and finish your question.
What's the difference between an IVB push and a drip?
It's just the method of administration. One is continuous, the other is, like you said, it's a bolus, it is an upfront, one-time dose.
And if it's gauged at 25 micrograms an hour, how much medicine is that person receiving in 1 hour?
25 micrograms an hour.
Showing you, for purposes of refreshing recollection, the medical administration records with James Allen.
Yeah.
Approach the witness, Your
You
Honor.
may.
Thank you. Oh, okay. Yes, I'm refreshed.
Okay, all right. So in addition to the 1,000 micrograms of fentanyl IV push, what, if any, benzodiazepine and the amount and manner did Dr. Husel order?
6 milligrams of Versed to be given IV push.
All right. And was this to be given at the same time?
Yes.
And you said these were verbal orders?
Yes.
All right. At this point, did you ask for clarification from Dr. Husel?
Yes.
And once again, why are you asking for clarification?
Similar to the first gentleman that we described, I wanted to just kind of understand his rationale. I need to hear, just like with any, I mean, it's not really seeking it because of the specific medication. Anytime that there's a new order placed, I want some sort of contextual reason as to why it's being placed. So this was me being like, hey, I know we're doing this for palliative extubation. Why are we settling on this dose? Secondary to the fact that this is a different dose than I had given the previous gentleman. So why is there this variation here?
Your training and experience at the time, were you aware of any synergistic effect between between benzodiazepines and opioids when administered at the same time?
Yes, I am aware of the synergistic effect between opioids and benzodiazepines.
Were you aware of that back in 2018?
Yes.
You recall testifying at a previous hearing that you did not have training on that and were not aware?
Well, I did not have any formal training on it, but that would have been something that was vaguely covered in one of those daily pharmacology things. To expand a little further, I would have heard the term synergistic effect before, but I had no previous experience from which to pull to say, oh, that's what the synergistic effect is. It had never clinically presented itself to me. I wouldn't even know what it looked like. But I knew that it's this esoteric thing that exists.
esoteric. Can you define that for us, please?
Oh, I don't know, just like theoretical thing that exists. Maybe that's the wrong word, but to me, that's how I meant it.
Theoretical.
Yeah, like, it had been touched on, but I have no idea what that appears like in practice.
Okay, thank you. So when you go to the Pyxis, how do you have to get these out?
Entering and pulling them, and since it's verbal, it would have been an override.
And same procedure as before regarding getting the multiple vials and having to put them into a single, well, two, one for the midazolam, one for the fentanyl.
Yeah, I'm not sure how many syringes I used, but it would have been the same process. I would have gone independently, overrode the medications, took them to the room, drew them up in a syringe, administered to the patient.
Okay. And so do you administer these before pulling out the endotracheal tube or after?
I don't remember. My assumption, I don't want to assume, so I don't remember.
Well, do you recall what your practice would have been?
It would have been to give them before.
All right. And why are you giving these doses, why are you giving him fentanyl and midazolam in your mind at this point?
Why are we doing it?
Why are you doing it? In your mind, why are you doing this?
Yeah, much similar to the first gentleman. This guy has a very bad lung injury. He's receiving positive pressure ventilation through an endotracheal tube. His ribs are probably sore from the CPR. He has lost pulses to that lower extremity. His lactic acid level is 20, which for reference, normal is 0 to 1. His is 20. And he has, as before, a Foley catheter and various other medical instruments in his body. And he has been receiving, he would have been on pain medication.
Okay. At that drip of 25 micrograms an hour?
Yeah.
Do you recall charting any of those, did you recall observing either in your mind or charting any active symptoms of pain during the course of the evening when you took care of him?
I don't recall.
Okay. If I were to show you the pain score charts, would that help refresh your recollection as to whether you charted any pain medication or pain score for him?
It would, and I guess I just want to be more, you're asking previous to the extubation or just throughout my care for him?
Yeah, previous.
Oh, yeah, I'm not sure. I would need to see that document.
Okay. Do you recall documenting any RAS scores for this gentleman?
Yes.
And do you recall what his RAS score would have been?
I believe I put it either a -3 or a -4. I believe someplace I indicate that he was withdrawing and grimacing.
Okay. But -3 and -4, what would that be regarding his level of consciousness?
He wouldn't be doing, he'd be out of it.
Okay. What about the CAM score? What's that? Do you recall what that is?
I remember it, and I'm confident enough, I believe, to say that that's like a CAM ICU. I think we did that for screening for delirium. I could be wrong, but that's seemingly is what that is to me.
May I approach the witness, Your Honor, for
You may.
purposes of impression, showing you the direct flow charting sheets from James Allen's medical records?
Thank you.
Read those, please.
Yeah, thanks. think that's a double.
Oh, okay.
Is this a repeat? Okay.
Sir, does that help refresh your recollection as to whether or not you charted any pain scores for Mr. Allen previous to his extubation?
Yes,
And did you chart any pain scores previous to his extubation?
I did.
And what were his pain scores?
I charted a 0.
And why did you chart them at 0?
I must not have appreciated any pain on that assessment.
Okay. So after you take out, either before or after you give him the medicine, and it would have been your practice to give it beforehand, you recall, do you recall if the family was in the room with you when this was going on?
I don't.
What happens next? What's the next thing you recall happening?
Much similar to the first gentleman, I would have exited the room, allowed them to stay, allowed them to take whatever time they needed. Was at the nurse's station, and then eventually, once the patient passed, the family alerted me that the patient had passed, or at least I went in once the flatlined, and we kind of came to the consensus that we believed the patient had passed, and therefore I called Dr. Husel to come to the bedside to pronounce.
Okay. And why are you calling Dr. Husel to pronounce if you can see that he's flatlined and no longer alive?
I do believe that there's like a physician obligation to have to pronounce. I can't, that's out of my scope of practice to pronounce death.
All right, so it would have been Dr. Husel, that would have been one of the things he had to have done because you don't have that authority.
Yes.
Okay. When you or others in the ICU document things, do you always do it in real time?
No.
Why not?
Sometimes you're very busy. You can take care of patients that are so busy to where sometimes you need multiple nurses to help take care of a patient. Sometimes you can't even use the bathroom. It's very busy. So my number one priority is to be there for the patient first. And sometimes that leads you to do several interventions. And then when you finally, if you get a chance to sit down, you go back and try to chart what you did to the best of your recollection. I would rather treat the patient then chart instead of charting and leave the patient to go through whatever it is they're going through.
Sure, makes sense. So when is back charting the right term?
Sure.
How would you describe it?
I'm charting to the best of my recollection if I'm not able to do it in real time. So we can use back charting, that would be fine.
Okay, and so would the times of things that happened when you were back charting be exact, or would they be to the best of your recollection?
They would be approximate to my recollection.
All right. Let's talk about December 5th, no. Sorry. Let's talk about October 24th of 2018. James Timmons. Do you remember this patient, sir?
Yes.
All right. So October 24th of 2018, how long have you now been at the ICU?
Over 2 years, 2.5 maybe, give or take.
Experience-wise, how are you experience-wise compared to many of your coworkers at this point?
Objection.
I'll permit it.
While still new, I had been seeking, I believe to try to gain entrance into anesthesia school. So I was going a little bit more in depth to sort of how things worked and things of that nature. So as I did that, they started to trust me with sicker patients. So I think I was respected on the unit. I by no means knew everything, but they began to trust me to teach new graduates.
And were you so doing back on October 24th of 2018?
That is correct. I was precepting a new nurse named Emma.
All right. You come on to shift October 24th, 2018. What, if anything, do you recall about James Timmons? What's presented to you in the huddle?
So I actually recall, I think, a lot. So I walked in, I came in the ICU back entrance. Mr. Timmons was in bed 4 in the ICU. And as I walked into the break room, which is where we got our handoff reports, coworker that I was walking in with, wow, that looks like a really rough night. Like, that seems like a labor-intensive night. So after about 5-10 minutes, we did our handoff and we got our assignments. I was told that I was going to be precepting Emma. So we were going to function as one nurse for the care of that patient. So I was assigned Mr. Timmons with Emma, and my first interaction, he was in bed 4, so we stopped. Like, after they told us we had bed 4, we left because we knew, okay, there's a crash cart outside the room. This is serious. We don't need to hear what's going on with patients that like, we need to get there now. So we went to that patient, and as it turns out, he was being taken care of by a nurse who was also precepting somebody. So the exchange of report was fractured a little bit because it was 2 new nurses trying to kind of get their wheels and get on course. But I'm kind of supervising that. While during report, because it went a little bit longer than usual reports take, and that's okay, he rapidly clinically decompensated. So as we're talking, I watched him on the monitor drop his pressures into, I believe, the 60s. Knowing, coupled just with what I'm seeing a crash cart, yeah, this is not good. So I told Emma, I said, I told the day shift nurse, stop giving report, go get Husel now. So she scurried off, got the doctor. He came to the bedside, he was out on the unit, and we instantly initiated several life-saving issues. And this is really without knowing why we were there yet. So we gave several medications that included sodium bicarbonate. We pushed that through an IV. That is trying to raise his blood pH. And this is all verbally. Dr. Husel's giving this to me verbally, so I am overriding these medications. We give sodium bicarbonate. We do a stat lab level check, and his potassium level is elevated, which places you at risk for cardiac arrest. So we did what's called the Potassium Cocktail, or the K cocktail, which is a way to artificially lower potassium levels to stop your heart from having a funky rhythm. So we gave calcium gluconate to stabilize the heart. We gave dextrose to raise blood sugar, and then we gave insulin to drive the potassium into the cells to lower that. We then broadened out antibiotics, and what we mean by that, or what I was led to believe that meant, is this was signs and symptoms of like progressively worsening septic shock. So instead of doing like specific antibiotics, just pick the 2 classes of antibiotics that cover everything. So he told us to do that, and then we ordered what's called a stress dose hydrocortisone. And I interpret that at the time to mean that whenever like some degree of stress on the body is good, it helps us mount a fight. So sometimes these patients who are in the ICU need medications, they need the steroids delivered because it helps them mount that ability to fight. It actually enhances the ability of the vasopressors, which he was on, the adrenaline, if you will, to work better. So all that occurred in the first 15 minutes of our shift. And that is fairly atypical. Like, people decompensate, but that may have been the first or second time that ever happened to me while talking. All right, I don't even know really why we're here, but we need to do something. And Dr. Husel was around the corner getting a report from the residents on the day shift. So me, him, and Emma are basically treating this patient having not even received a full what happened for today. So that's the start of the day.
What happens next?
So he continues to have these episodes throughout the night. His brother is called to the bedside. I'm not sure if I called him or if he was there, but Lynn was there, and we updated him with the situation. You know, he is very unstable to the point where he's swinging one way to the other pretty quickly, minutes really. And I said, you know, we kind of handled that part, but like we're by no means out of the woods. I remember telling him that. And he said, oh, well, it looks like we're going to make it through the night. And I said, no, we will not. I didn't say no, we will not. I said, no, I'm not even thinking about it like that. I'm trying to make it through the next 30 minutes to 1 hour.
I'm going to stop you there.
Yes.
Lynn, when you say Lynn, who are you referring to?
I believe that's the patient's brother.
Okay. What happened next?
So Lynn left, despite us telling him he probably shouldn't. Throughout the night, we were going up on the vasopressors and trying to treat all of his issues secondary to why he presented. I ended up calling Lynn back, and Lynn came, and we updated him with, we had one more episode of sort of that dramatic sort way. He wouldn't want to live like this. I don't want any of this. SHIT, take it away. And then much similar to the other two patients that I previously discussed, said, I get what you're saying, but I got to call the doctor. The doctor was called. Husel came to the bedside, and we went from there.
When you say you went from there, what happened next?
So we discussed the goals of care, which was now Lynn's, his brother's willingness to withdraw and make a DNRCC. We told him, and we did have this conversation, that we were going to give him pain medications to let him pass peacefully, naturally, pain-free. And we did talk to Lynn about his drug use and his history. We said that he's received a lot of medications throughout the stay. He's coded many times throughout the stay. We talked about, we didn't discuss the use of fentanyl per se, but we said we were going to have to use like higher doses because of his tolerance. And then we basically told Lynn, and I remember telling Lynn this myself, I said, we're here to do whatever you tell us to do. If you want to keep going, we go. If you don't, we can stop this. It was, you know, and then the decision was made to withdraw care, and then, yeah.
Do you recall what time of the evening this would have been in? Or
It was early morning, so after midnight.
if the records reflect, or is a note signed by Dr. Husel at 3:27 a.m., does that sound right?
Yeah, that sounds appropriate.
All right, so this is on October 24th. So what happens next?
So I think it's important to note here that Emma's great, but Emma also was very limited because she was new. So I was very busy with Mr. Timmons. So there was another nurse that was helping me throughout the night. So really we had like 3 nurses, but Emma was just learning. So it was me and a nurse named Earl. He would pop periodically in throughout the night and help me do all the cares for the patient. Sometimes he would help intervene. He was always on nearby because we knew that at any minute this guy could go the opposite way. So after the discussion with the family stepped out for that one. They went with the palliative care, or not the palliative care, the chaplain, which is like the I don't really know what the chaplain does other than just kind of help, like a liaison between goals of care. They went with the chaplain to talk, maybe do a prayer, I'm not sure. In that time, Husel was at the seek clarification as to why we were doing that dose. I believe it was either Earl or Emma who pulled those drugs for me. They came back, they handed me the drugs, I had already received confirmation that my clarifying questions were answered by Dr. Husel. I drew up the medications and gave them to the patient. Exited the room, all of us exited the room. Lynn came back into the room. He was spending time with his loved one. Dr. Husel and I were sitting right across from bed 4. There was a nurse's station. We sat right there. About 5 minutes later, the brother opened up the door, pulled the curtain rather, because we had the curtain pulled. And he said, help, help, somebody come quick, he's in pain, somebody do something. From where I got up, I went into the room, Husel followed behind, and what I saw was not great. He was kind of grayish blue, more so gray. He had kind of like foam at his mouth a little bit. He was rocking the paradoxical breathing. The brother was in distress, crying, and it just, yeah, that's what I saw. And from there, I don't know if Earl had heard this noise or the family member calling out. He came back like he did that night most of the time, and Dr. Husel gave another verbal order for more medication.
Do you recall the medication and the amount that he gave a verbal order for?
The second time,
Yes.
it was 10 milligrams of Dilaudid and 10 milligrams of Versed. Once again, I didn't pull those medications. Earl came back with a lot of medications. He had those medications, but he also had Ativan as well. I don't know where that came in. I don't know. He must have talked with the doctor. While this was happening, and I can't remember if it was right before dose number 2 or right after dose number 2, I can't say, but I called the pharmacy. Called and spoke to pharmacist Talon Schroyer, and I told Talon Schroyer, we are doing a palliative extubation on a patient that has a really big opioid tolerance. He said, wait. He pulled up the MAR on his end. I pulled it up on my end. We could see every medication that was out of the Pyxis. And I said, this is what we're doing. This is what we're giving. But I also have this Ativan and additional Versed that I don't think I need because the doctor said give him what he needs, but not too much. So I was calling to say, hey, this is what we're doing. These are the meds that I'm giving. But then also, I was also calling him to say, hey, I'm also don't want to be responsible for these other medications that the patient doesn't need, and the physician said he didn't need them. I don't want to be, they were handed to me. I don't want these I don't want to be responsible for these. What do I do about that? And like I said, I couldn't remember if that was before or after dose number 2, but I ended up giving the 10 milligrams of Dilaudid and 10 milligrams of Versed. I later then returned the medications that we didn't use.
That would have been the Ativan?
And I think there might have been even Versed there as well, but I know that there was, at least Ativan was returned. There was a weird discrepancy in the Pyxis where it appeared like we gave him more Versed than what I actually administered. So the total dose that the patient received was 1,000 micrograms of fentanyl, 10 milligrams of Versed, 10 milligrams of Dilaudid, and 10 milligrams of Versed, all in the, in that time that I detailed. And then we returned whatever medications were left over because we didn't want to give him too much.
So when you return, does that sometimes show up on the Pyxis log as wasted?
I think so. I say return. It very well could have been a waste. I know that I went with the nurse who pulled them because that was who the fingerprint was on who got them out, and we did something to take account that they're not being given to the patient and being disposed of properly. Either returned or wasted, I don't remember. I just say return because that's what I think.
All right. Let's talk about the call to pharmacy.
Yeah.
You recall on your first palliative extubation calling Greg White.
I did.
You recall seeing Greg White on the floor thereafter.
Yes.
You recall him at least going to the room with Dr. Husel.
I just remember him being on the floor.
Okay. You're not aware whether or not he actually had a conversation with Dr.
No, I
Husel.
wasn't. If he did, I wasn't a part of it.
You did not testify about calling pharmacy on the second palliative extubation.
Correct.
Now, this third extubation, you did call pharmacy because of this Ativan, that Earl Huron, is that who we're talking about?
Well, it wasn't just because of the Ativan, but that was a part of it, yes.
All right, and talking to Talon.
I did.
And so this would have been the first time you have talked to Talon about these drugs, these doses, and what the particular procedure is being used for?
Yeah, to my knowledge, I had never spoken with Talon in regards to a palliative extubation before. I had talked to him numerous times because he was a night shift pharmacist, but in the context of withdrawing on a patient, that was the first time I called Talon, and I told him that we were doing it for a palliative extubation.
All right. Was there another reason calling Talon besides the waste? Or the extra drugs, I'm sorry, besides the extra drug?
Yeah, just like, I think I was just kind of like, hey, we're giving these medications because this guy's a chronic opioid user. To me, it's just, that's a lot of medications to be out of the Pyxis at once. So I wanted him to know this is what they're being used for, this is why they're being used. It's a guy who has a very big tolerance to medications because he was admitted, and it turns out that there was something with his drug use. And then I also didn't want to be responsible for medications that were just freely floating around the unit. So it was kind of twofold.
Was it a common practice in the ICU at night to have one nurse pull medication and then hand it off to another nurse to administer that medication?
I wouldn't say that it was common, but I can't say that it's uncommon. You know, like in a code situation, nurses would hand medications across the patient as you're doing CPR and say, that's epi, push it. You know, there are nurses who would grab bags out of the Pyxis for you. If you're in a room, you're like, hey, override this or not override, I'm sorry. That's not the word I wanted to use. Grab this medication for me, please, just because I'm in the room and you're at the Pyxis. So maybe that's not the best practice per se, but that occurred on the unit.
Okay. And going back to whether this is an emergent situation or not in your mind, is this palliative extubation of James Timmons an emergent situation requiring, like, you described a code with the epi thing, right? That's
Yeah.
an emergency, that someone's flatlined, right?
That would be what the code is, yes.
Is, in your mind, James Timmons the same type of emergency?
In my mind, I do. I do believe that to be an emergency. I see rapid clinical decline. I see a night full of swinging blood pressures, vasopressor use. The family is distraught, and now he's asking for more medications. Like, to me, that is, I would say that's an emergency for me.
Yeah, well, I'm talking about initially, because didn't Earl pull the 1,000 and the 10 initially too?
Well, I don't know why he pulled those. I mean, I know he did pull them, but I wasn't a part. I can say that if Earl didn't do it, I probably would have overrode those medications too. But I don't know if Earl thought it was an emergency or not. I have no idea what he was thinking.
Did you ask Earl to pull those medications up for you?
I don't know. I don't believe so. I'm not sure.
Was Earl part of the care of James Timmons that night?
He wasn't assigned to him, but Earl was very helpful in his care because he had experience as a nurse and was my neighbor. He was taking care of patients next to Mr. Timmons. So it was very common in practice for nurses, even if you weren't assigned to care for that patient, you would go in and help because they're people that need help.
Sure. Well, since this has been brought up as an issue, a possible issue, were you stealing those drugs?
No.
Were you aware of anyone stealing those drugs?
No.
These practices you describe, I'm sorry, I've been told to be quieter. So these practices that you've described, and Judge, I look this way just to project that way. If I can just kind of do it this way.
That's fine, just.
Okay. These practices that you've described of one nurse grabbing them, giving them to you to administer, to your knowledge, did that involve anybody stealing drugs? To your knowledge?
No. Everything that was ordered, I received in their entirety, and I drew them up and pushed them.
Okay.
Nothing was unaccounted for. If the order was 1,000 of fentanyl, there was 1,000 of fentanyl there.
All right. And if the records reflect that you gave Mr. Timmons 1,000 of fentanyl, that's actually what occurred?
Yeah, I gave it to him.
All right.
Intravenously.
And then you also gave him at 3 o'clock the Midazolam too, the 10 milligrams of Midazolam.
I did.
All right. So how soon after giving those drugs did Lynn come out and say he's still in pain or whatever he's saying to you, he needs more pain medication? How soon after that initial dose do you recall giving him that second dose?
Roughly approximately 5 minutes, 5 to 7 minutes maybe.
Your knowledge in 2018, how quickly does fentanyl and midazolam work in a person's body?
Objection.
I think you need a little bit more sustained.
Were you aware of how quickly midazolam and fentanyl worked in a person's body in 2018?
Specifically, no.
Okay. So you hear Dr. Husel give another verbal order at 3:05. Does that sound right? You said about approximately 5 minutes later?
Yeah, roughly.
Hydromorphine, that's also Dilaudid. That's just the name brand.
That is correct.
10 milligrams of that,
Yes,
and that was IV push.
it was.
And then another 10 milligrams of midazolam,
Correct.
and that was also IV push.
Yes.
And that was pulled by Earl because it was kind of urgent at that point.
I think it was Earl or Emma, yeah. I think Earl, I'm comfortable saying Earl.
All right. And did you prepare those doses, or did Earl prepare those doses, or did Emma prepare those doses?
I don't know about the second one.
All right.
I'm the one who gave it.
And you have a memory of giving those doses IVB push at 3:05, approximately.
Approximately, I do. I was the one who administered them.
What happened next?
The patient's family member thanked us for more meds, and we went back to our standard outside the room. You know, I kind of monitored the situation for a second. I suctioned his mouth because there was the stuff hanging out of it. He looked, the paradoxical breathing was maybe a little bit better, but I left the room. You know, to me, it's more about the family being in the room. You know, I want to stop being like, oh, let me do this assessment, let me do this. Like, the vasopressors are off. Like, those are out of your system and very quickly. Like, he needs to be here, and I need to step back here a little bit. It's less about me and more about his last moments being with his family member.
Okay. Prior to his extubation, do you recall whether or not you charted any active pain in Mr. Timmons?
I let Emma do most of that charting, so if it was, it would likely be under Emma, aside from the dose that I gave palliatively when I recorded a pain score.
Okay. Is there anything I could show you regarding whether or not pain scores were charted during this time?
Yes, please.
Okay. Showing you from Mr. Timmons' medical records the direct charting flow sheet. I was just going to show him this. Is that okay? May I approach the witness, Your Honor?
You may.
Thank you.
Does that help refresh your recollection as to whether any pain chart, in the pain chart, if any pain scores were recorded?
Yes, it helps refresh.
What were the pain scores that were charted during your care of Mr. Timmons?
Emma, and which I guess means me, charted zeros.
Okay. And why is Emma charting that as your preceptor? Are you instructing her, or is she doing this on her own?
I'm letting her do her own assessments. Ultimately that's her charting, but I'm making sure more so that she doesn't record something off the wall like a -2. Like, she had her own process of how she comes to that number. As long as she has a why as to how she got to that number, I'm okay with that. I'm signing off to make sure that she's keeping the integrity of the process, more so than, I'm not telling her, that's a 0 because of this. Like, the way that I would educate is I would allow her to come to her own conclusions, and as long as she had a rationale as to why that is her conclusion, I'm okay with that.
Do you recall that being an issue? Do you recall seeing Mr. Timmons in any pain, grimacing, the things you've described, which would indicate pain for somebody on a ventilator, that would indicate Emma's not correct there in the 0 pain score?
I do believe he's on a fentanyl drip at the time. So what I can say to that is maybe he didn't need a PRN breakthrough while on our shift, but he was already requiring something to control pain. So I don't know if that answers your question.
Well, the question is did you observe Mr. Timmons to be in any active pain while you were taking care of him?
I'm not sure I can recall that.
Did you ask for clarification from Dr. Husel in front of Emma when these doses were ordered initially?
Yeah, both times.
And what was the purpose of asking for clarification from Dr. Husel? This is now the 3rd time, and the same doses approximately as the previous 2.
Yeah, sorry. 2 reasons. The first is less important, but it's a reason, is Emma needs to know that she can approach doctors. She needs to see that it's very scary sometimes for people to talk to a doctor and say, hey, what do you mean by this? Especially being new. Fortunately, he was approachable, so I wanted her, she was going to be working, I want her to see that 1, it's an expectation that you clarify. 2, it's okay to question doctors even when it's scary. 3, the doctor that you're going to be working with is approachable and respectful when you come with questions. And then 4, I'm still seeking that same clarification. At the end of the day, I'm still responsible for that patient. So it's kind of fourfold. It's an education thing for Emma, but it's also like, hey, this is still Mr. Timmons here. This isn't, as much as Emma's education is important, Mr. Timmons is the priority here. So I need to make sure that we're on the same wavelength as to why we're administering these dosages.
Okay. So that was October of 2018, October 24th, so it's the end of that month, getting to the end of that month. In December of 2018, so about 5 weeks later, give or take, do you recall being summoned to HR?
Yes.
Why were you summoned and what happened then?
So I'm not sure I ever actually worked a shift after that. I think I went on like a vacation or something, and I was placed on administrative leave. I was summoned to HR for what they told me was a fact-finding endeavor. That was their words. They asked me questions about ICU practice, about overriding medications, and they asked me about, that's really what I remember.
Okay. Were you thereafter taken to another room and asked to speak to the police?
No, so I actually was summoned to a meeting from HR. I think I met with Katie Barga. I think that was her name. she kind of vaguely alluded to what ended up, what we all know now, but it was very like, oh, this is just us, finding some facts, nothing's gonna happen, stuff like that. Then, give or take sometime later, I was called and said, hey, come to Mount, because I'm still on administrative leave, so that's my job. They say, come to Mount Carmel West. It's not the hospital, but there's an attached building, which is like where the big wigs sort of have their offices. Come there, we're gonna do a little bit more questioning. I went there, so it's the second time I went back, and I was told then, spur of the moment, that I'm going to meet with Columbus homicide detectives.
Did you thereafter meet with them
Oh yeah, I did.
and made a statement?
Oh yeah.
Okay. And what's the next thing that happened regarding, you were on leave from what date, do you recall?
I don't recall. I know that what ended up happening with me,
Objection.
Okay, I'll permit the answer for now. Go
Just
ahead.
at Mount Carmel is all I'm talking about.
what happened next,
And I'm talking about when were you placed on administrative leave, if you recall, from Mount Carmel? So this was before you met with the police, you're already on leave?
I think, it's vague to me because I ended up leaving Mount Carmel. I resigned on January, I believe, 19th or mid-January, I resigned from that position.
In 2019,
2019, yes,
while you were on leave?
while I was on leave.
Okay, very good.
They had,
Okay,
I'm sorry,
yeah.
yes, I'm done, yeah.
We do by question and answer.
Yes, sir, I'm sorry.
Just a few more questions about James Timmons.
Okay.
You had mentioned that he had been on a drip, you had knowledge that he had been on a drip of fentanyl that evening or previous.
Yes,
Do you recall the amount of drip he was receiving per hour?
I do not.
Is there anything I could show you which would refresh your recollection as to the amount of drip he was receiving?
Yes,
It's right there. It's the 25 micrograms.
okay, thank you.
Does that refresh your recollection as to his previous drip?
Yes,
What was he receiving?
175 micrograms per hour.
Do you know what that white foam in his mouth you described after you gave him the 1,000 microgram push was from?
No, I have no idea. I know it's secretions. I don't know why it's caused.
Had you seen that before in any other patients?
Not like that. That was significant. Like it was, almost looked like an Alka-Seltzer tablet was in his mouth.
Had you ever treated anybody that was actively overdosing on fentanyl?
Objection, Judge.
Well, I'll permit it.
No.
Thank you. No further questions.
Ross?
What? Oh, I'm sorry. Just, yeah, I gave you one
That's all right.
last week.
Yeah.
Thank you, nothing further.
Cross?
Please report. Good morning, ladies and gentlemen. Good morning. Good morning, sir.
Good morning.
I want to start from the beginning of your direct. You were asked if most of what you learned, your first, I guess, most of what you learned was from Dr. Husel. Do you recall that?
I recall them questioning me that.
Okay. But you, in fact, had learned quite a bit from your preceptors, right?
Yes, I learned from other nurses, respiratory therapists, and I did my own independent. I said I bought books. I was reading at home. So he taught me a lot, but it was not, I learned from everybody.
In fact, you learned from your preceptors and other more experienced nurses that 1,000 micrograms of fentanyl was an appropriate dose during a palliative withdrawal. Isn't that correct?
I was told that it's patient specific and that would not be, so like that is very well possible.
Okay. Do you recall in another proceeding giving a deposition in this case?
Yes.
Okay. And do you recall that date was February 26th of 2020?
Yes.
Do you recall when discussing Mr. Millett that you testified under oath that it was an appropriate dose?
Yes.
And then later on you were asked, you said you were trained that it was an appropriate order. Who trained you that this was an appropriate order? And then you answered, my preceptors. I mean, just the way that a nurse learns. Aside from that, you know, you gather, maybe in school, you learn primarily how to function in your role. It's almost like a residency.
Yes, that,
Okay, you answered the question.
yeah.
Okay. So you would agree that your experience, on-the-job experience, is quite a teacher.
I would say that is probably the best teacher.
Okay, so if you had certain experiences, you would utilize that in perhaps your next patient that you run into a similar situation, right?
Yeah, I try to store those experiences that leave a lasting impact, and I tap into those for my future treatment. It helps shape my practice.
Okay. Now, I want to talk a little bit about Mr. Milletti. Are you familiar, you testified under direct examination about acidosis. Do you recall that testimony?
Yes.
And you utilized it as a gauge as one of the factors as to why you took into consideration
Reasons correct.
Okay, and are you familiar with the pH range that's compatible with life?
Yeah, and I'm familiar, I would have been familiar with that in my practice, back then as well.
Okay, and you know that it ranges, what's the normal range?
So the normal range, textbook range, is 7.35 to 7.45. For simplicity, most people just say 7.4. That is the scale.
I'll
Yeah.
get into it a little bit more.
Okay.
And I want to show you a document in reference to the scale and see if it looks familiar to you.
Okay.
You may. Did you show the other side?
Yes. I did. Does that fairly and accurately describe what you understood at the time that you were working on with these patients, what the pH scale was?
Yes.
Okay. May I publish, Your Honor?
Any
Object,
objection?
Your Honor, as to its relevancy with this witness.
It was
He's
brought
not
up
an
there.
expert, this is something he didn't prepare, this is nothing he has experience with, he's not here to testify regarding any of that.
Counsel brought out during direct examination his consideration of the pH levels. And this witness is familiar with the pH scale, and this is what he utilized to analyze whether
No,
this
that
was
isn't
an
what he said.
appropriate
He
dose.
didn't utilize that document. That was the first time he saw it.
But he utilized the scale. This is all this is the scale. It's not some document.
Sustained.
Sir, on the pH scale, you said that 7.4 is right where you want to keep your patient, correct?
Yes.
And you're familiar that Danny Millette was at 6.96, correct?
I am familiar with that value.
Okay. And 6.96, or actually, at what point on that scale is it not compatible with life?
For me, in my practice, it begins to tread on fatal at or below 7.2. So if I see anything less than 7, that is significant. That is, we need to either change something or everybody needs to get on board with what the goals of care are. That's not compatible with life. Under 7 is, you won't live.
And could you explain to the ladies and gentlemen of the jury what pKa levels are and how that relates to, based on your training and experience, the pKa levels and how that relates to the administration of fentanyl?
Objection, Your Honor.
Sustained.
All right, let me ask you this. Are the pKa levels something you would have considered when making the determination whether a dose is appropriate?
Objection, Your Honor.
Sustained.
When you questioned, or when you clarified, I should say, the order with Dr. Husel, and he gave his explanations, was the pKa level something you considered?
Objection, Your Honor.
I'll permit that one.
At the time it was mentioned, I did not understand what it meant per se, but it was definitely something that was mentioned.
Okay. Now, you mentioned that Mr. Millette was a pretty sick man.
Yes.
And at the time of his palliative extubation, he was actively dying?
I believe so.
Okay. And when someone is actively dying on full life support, is that an emergent situation?
Actively dying, yes.
Okay. So, when did the family approach you in reference to doing the palliative withdrawal?
What I can say is they were updated with the status, but for Mr. Millette and all of these patients, the decision to switch code status to DNRCC was the family-driven initiative. It was not, every time we would conclude with, we will do whatever it is you want us to do. We will keep going, but if you don't, just let us know. We are there for you.
I forgot to mention this. There was a lot of testimony in your direct about your inexperience and your training. this palliative withdrawal actually occurred a year after you had started, correct?
Roughly, yes.
And this is a year of working in the ICU, correct?
Yes.
A year of working with preceptors or other experienced nurses?
Yes.
And this is having to see several other, or I should say many other palliative withdrawals, correct?
I've seen other palliative withdrawals, yes.
Prior to ever having to do or be in charge of Danny Millett's palliative withdrawal?
Yes.
So you weren't exactly a rookie, so to speak? For lack of a better word.
I don't know what the value is to where you become a veteran, but I had seen some before. This was not my first palliative withdrawal.
Okay. Now, you mentioned that Dr. Husel would sometimes pull you aside and train you as well as other nurses?
Not just nurses, techs, even people that are just like stocking rooms that want to go to school, respiratory therapists, everybody who worked on that unit, he was an open resource for.
And this is a teaching hospital, is it not?
Yes.
So it's not unusual to teach other healthcare professionals while on the job, correct?
I agree.
And in your experience, Dr. Husel was always approachable?
Oh, 100%. I mean, he was... I have been at many different hospitals previous to that and since that, and there has not been another physician that I have encountered that didn't make himself available as he did, didn't freely educate as he did. Sometimes it's like pulling teeth to get them to give you something. And I've seen him go what I believe is above the duties that some of the physicians I've worked with usually do.
Now, you have, as your experience grew in Mount Carmel, you then became part of what is called a code team, did you not?
Yes, I was part of the Code Blue team.
Tell the ladies and gentlemen of the jury what that is exactly.
So, since ICU nurses are required to have, or at least at Mount Carmel, they were required to have advanced training in life support measures and saving people in emergencies. I had that, and I have that. 2 nurses from the ICU would be placed on what's called a Code Blue team, as well as the attending physician in the ICU, which some nights would be Dr. Husel. So what that means is anywhere, any place in the hospital, if there was a code where a patient died, those 2 people, the 2 nurses and the doctor, would be responsible for going to that location and trying to bring them back.
And is this something that an ICU doctor has to do?
I don't know. I know that,
Okay, you answered the
yes,
question?
I don't know.
But you say that Dr. Husel, I guess, during work would go above and beyond.
Yes.
Okay. And as a member of the code team, did you have the opportunity to do codes with Dr. Husel?
I've done a lot, yes.
How much is a lot? Give us a little more context. More than 50, less than 50?
More than 50, I think a good number is 70, 75.
So about 75 times you witnessed Dr. Husel saving lives.
Well, it's on the code team, yes, but there's more than just that. You know, I can recall a moment where there was something paged overhead. It was a level 1 trauma. So
at this point, I'm going to object as to relevancy.
Sustained. It's time for lunch anyway. Ladies and gentlemen, if we start back up at 1:15, will that give you guys enough time for lunch? Well, which would you prefer? Not that it's your decision, but it's mine, but 1:15, this door safe? Okay. Remember the admonition, we'll get started accordingly.
All right.
Have a great lunch, guys. Sir, you may be excused until we come back at 1:15. Remember my prior ammunition. Mr. Byers, you're on the floor. Anything for the record?
Nothing from the defense.
Mr. Zion?
No, Your Honor, thank you.
Both of you two have taken shots at me about what I told you the other day. Okay? Really? You're gonna act like that with me?
No, I'm not acting.
You made the comment about alluding to him getting too close and directing in there. You made the comment about being directed out. I'd be more than glad to explain to the jury. I don't think you want me to.
No,
Why I did. So, you know, you can take your shots, but let's do it at an appropriate time. You're not bothering me what you're doing right now, and
That's what I
Mr.
was
Zion wasn't bothering me what he was doing. Okay? It's when you got all the way over by the rail and got in there that bugged me.
I did, Judge?
Yes, you did.
I wasn't aware I did that, Judge, and I apologize if I did to both court and counsel.
It wasn't today. This is from the past.
Oh, okay. Yeah.
Okay?
I'm aware.
No
of
one
the
got
court.
over there today. Mr. Zion came over because he had to bring the exhibits, but he got out of the way of the jury, which was fine. Okay?
Sure.
Anything else for the court?
No, sir.
Have a great lunch, guys. 1:15.